Thank you very much. So first of all, thanks for having me here. Today I am a postdoc fellow at the Azrieli National Institute for Autism Research at Ben-Gurion University in Israel. And I will be speaking about the work that I've been doing over the past several years as part of my graduate school at the University of California Mayan Institute, where we worked on trying to understand trajectories of autism symptoms across childhood. So we all know, right, that autism is a neurodevelopmental condition. And according to the latest CDC report, it affects every 1 in 44 children in the US today. And because autism does not have a specific biomarker yet, so there's no kind of genetic or blood test that we can identify autism with, we assess the presence of autism behaviorally through the presence of 2 core symptom domains. The first are the social communication symptoms and the restricted repetitive behaviors. And that's what we look for in a person's behavior when we're trying to assess whether they have autism or not. So there are 2 core symptom domains. The first are persistent deficits in social communication and social interaction. I'll just go briefly a bit over the symptoms themselves. So the social communication deficits are comprised of 3 subcategories. The first subcategory are deficits in social emotional reciprocity. So social emotional reciprocity is what we see in reciprocal interaction, like an infant playing peekaboo with their parent. Or for older children, we'll see reciprocity in taking turns when playing at school, for instance. For individuals on the spectrum, we'll see deficits in these kinds of abilities. The second subcategory in this symptom domain are atypical nonverbal social deficits in atypical nonverbal social behavior. So, for instance, that would be a difficulty in using eye gaze to promote communication, or creating that synchrony in different modalities of communication, such as syncing eye contact with use of gestures and intonation and the verbal message, just thinking all these different components in communication. And the third subcategory in this symptom domain are deficits in forming and maintaining relationships. So, for instance, we'll see that children are not trying to engage other children or seeking out to be close to them as we would expect to see in younger ages. And later we'll see children that have challenges in creating relationships with their peers. And a lot of time they'll just go to the adults in the area to try and create relationships in their environment, to try and create relationships instead. So these are the 3 subcategories and within social communication deficits. And to receive a diagnosis of autism, an individual must have symptoms in all 3 subcategories. The second symptom domain are the restricted repetitive patterns of behavior, interests, or activities. And this domain also includes a range of different behaviors. So this domain comprises 4 subcategories. The first are the stereotyped repetitive idiosyncratic speech, motor behaviors, or repetitive use of objects. A lot of times, this is the hand flapping that we see done by a lot of people diagnosed with autism. Repetitive speech is something that we see a lot of times, and it can also be repetitive play. For instance, a child that sits with a jack-in-the-box and they just push it again and again and again. So these are repetitions that are not happening to reach some kind of goal. This is just repetition for the sake of repetition that we see in these types of behaviors. The second subcategory in this domain is excessive adherence to non-functional routines. This is what is called insistence on sameness, the need for things to be the same over and over again. So it can be eating the same type of food every day. It could be going to school through the same road every day, or wearing the same sandals to school every day, even though it's winter now and it's raining and no one else is wearing sandals. The third subcategory are the restricted fixated interests. So these are just highly intense interest areas that some individuals on the spectrum have. And these can include different types of interests, like space or Star Wars, which are more like socially acceptable areas of interest. For really for toddlers, and it can be numbers, but sometimes it can be things that seem a little more bizarre, like the technical structure of fountains, for instance. I once diagnosed a child that every Saturday they used to pack up the family, get in the car and drive to another fountain in their state just to understand the structure of that fountain. So that was that child's specific interest area. And the fourth and last subcategories in the RRBs are atypical sensory behaviors. And these can go in either direction. So they can be sensory seeking, needing sensory input, like that toddler that sits in front of the washing machine and just watches it spin and spin to get that spinning, to get a visual input of that spinning motion. Or the other way, it can go to trying to avoid sensory stimulation, like the child in the photo. She's putting her hands on her ears because she's trying to avoid the noise, or children who avoid certain types of smells, for instance, because they just can't stand the sensory input. So that was just a very, very brief review of the two symptom domains that I'm going to be talking about today. So these two core symptom domains, the social communication symptoms and the RRBs, range in their severity levels, and they can go from low severity to high severity across different individuals on the spectrum. Different people would have different severity levels to their symptoms. So before going to the US and going to graduate school, as was mentioned, I'm a licensed psychologist, a clinical psychologist, and I did my clinical residency in specialized ASD preschools here in Israel. So in Israel, when a child is diagnosed with autism, their parents are able to choose to have them attend a specialized ASD preschool or daycare. Daycare run from 18 to 36 months, and preschools run from 3 to 6 years, so they include kindergarten. And every school includes 8 children and about 15 adults. So 2 special ed teachers, 2 speech pathologists, 2 occupational therapists, 2 psychologists or social workers that also function as case managers for the children, and a director, and about 3 to 4 aides per school. So and these schools are also funded by the country. So when I went to one of these preschools to do my clinical residency, and what was immediately obvious to me was how different each child was. So the children were very, very different from each other in all characteristics, but also in how their core symptoms, the social communication and the RRBs, how they manifested in each child. But what was also obvious is how children differed in the way that they changed over time. So some of these children, they were making these very exciting gains as the years went by and they grew older. They were becoming more engaged with their environment. They were developing communication skills. They were showing interest in other children. They were forming relationships with the staff. But other children, regardless of all the intervention that they received at the school, and all children received the same amount and type and intensity of intervention, some of these children, despite this intervention, it seemed like their autism, their core symptoms were getting worse over time. So they were becoming less and less engaged with their environment. They were mostly interested in doing their repetitive behaviors or just focusing on their specific areas of interest, and they were just, it felt like they were losing communication skills instead of gaining them over time. And these children are what later led me to my research question, which is, does the severity of autism symptoms change across childhood? And if so, how? So today I'll be showing you work in which we examined children's autism symptom trajectories from about age 3, which is the beginning of early childhood, and up to age about 11 to 12, which is middle childhood. And we wanted to answer 3 questions. The first is, how common is change in the severity of autism symptoms across childhood? The second was, does change differ between childhood periods? And the third, what would predict a child's either increase or decrease in the severity of their symptoms across childhood? So let me just tell you a little bit about the Autism Phenome Project, because our study is part of a larger study, which is the Autism Phenome Project study. This is a longitudinal study that was started in 2006. So it is about now in its 18th year. And it includes nearly 700 families with children that either have a diagnosis of autism or typically developing match controls. And the children are evaluated across 5 time points, starting at early childhood and up to early adulthood. So the goal of the Autism Phenome Project is to identify clinically meaningful subgroups of autism to better inform etiology, mechanisms, treatments, and outcomes in this area. And I don't know if I mentioned it, but the Autism Phenome Project is held at the University of California, Davis Mind Institute in California, in the US. So the Autism Phenome Project collects and focuses on a wide array of variables and aspects in people's lives, starting from the developmental area. We look at changes in IQ and in autism severity, which is what I'll show you today. Another area that is evaluated is clinical and psychopathology, looking at individuals' anxiety levels, depression, and of course ADHD. Which has a high comorbidity on the spectrum. Also, the medical area is another focus area, looking at GI symptoms, looking at genetics for the participants of the study, and of course, biological variables. So biological sex, immune functioning, and also the brain development, brain differences. All these areas are evaluated for participants in the Autism Phenome Project. So a very wide assessment battery is collected. It includes blood samples, different types of parent questionnaires, assessments are done, cognitive language behavioral, there is a physical exam and medical history, and there is also nighttime MRI scan during sleep without sedation. And as children grow older, we also look at memory and attention and academic skills for school. Like I mentioned, we look at different clinical aspects, different mental health co-occurrences that they might be dealing with. And as they grow older and go into adolescence, we look at puberty and different variables related to puberty. So this slide just shows you a brief review. So children come in starting at early childhood at time 1. at around age 3, and later to another 4 time points, with the current time point that is being collected is time 5, which is kind of the adolescence time point, with children with a mean age of about 16 and a half. And what is also interesting about this sample is that it is very inclusive. So the sample includes about 35% girls diagnosed on the spectrum. It is also inclusive to different levels of autism symptoms and different intellectual abilities. And also, it's not mentioned here, but these children undergo, most of these children undergo intervention in the community. So different types of intervention and usually high intensity of intervention. So the sample that I will be talking about today is a subset of the larger sample from the Autism Phenome Project. We evaluated 183 children, all diagnosed with autism. 128 are boys and 55 are girls. So we have this ratio of a nice ratio of about 30% girls, which lets us evaluate sex differences as well. And we used 3 time points to evaluate symptom trajectories. So our first time point is time 1, which is ages 2 to 3.5, with a mean age of 3 years. And this is around the time of receiving diagnosis. Children usually receive a diagnosis and then they enter the study rather quickly. And this is our beginning of early childhood time point. We later evaluated the children at time 3, which is ages 4 to 6, with a mean age of close to 6, 5 and 8 months. And this is our end of early childhood time point. And our third time point is time 4, which is our middle childhood time point. Children are 9 to 12 years of age, and our mean age is about 11 and a half for this time point. In order to evaluate children's autism symptoms, we use the ADOS. I assume that many of you know the ADOS. The ADOS, the Autism Diagnostic Observation Schedule, is the gold standard tool for assessing autism symptoms in both research and in clinical use. The ADOS is a play-based assessment. It is comprised of a series of tasks. Some are structured, some are more semi-structured, but the overall atmosphere of the ADOS is play. It's a play-based assessment. And using these different tasks and different play and games, they just allow the administrator to have these naturalistic situations to evaluate autism symptoms in. And the ADOS is the measure that we used to evaluate children's autism symptoms. In 2009, the ADOS was added what is called the ADOS Calibrated Severity Score, or the CSS. The calibrated severity scores are a standardized 10-point severity metric. They run from a 1 to a 10, with 1 being the least severe and 10 being the most severe on the metric. And 4 is the cutoff score for receiving an autism diagnosis. Now, because this is a standardized score, it allows us to compare children's autism severity levels, both between different children and within a specific child across ages and development, and also across different individuals that have very different cognitive ability and language level. So we are able to use the standard score to compare different severity levels. So we use children's ADOS calibrated severity scores at the 3 time points that I showed you, at early childhood, the beginning of early childhood, which is age 3, the end of early childhood, which is age 6, and at middle childhood, which is age 11 and a half. We use these scores in order to create trajectories, symptom trajectories across childhood. So what I'll show you today are findings that we published in a series of papers in which we evaluated trajectories of autism symptoms in the children of the Autism Phenome Project. And also, I will also show you some unpublished findings that we're still trying to think through. So our first question was, how common is change in the severity of autism symptoms across childhood? And what you see here is that we divided the children in the sample based on how they changed in their autism symptoms during early childhood. So from time 1, from age 3, up to time 3, which is age 6, from age 3 to 6. And we found 3 groups in the sample. We found in blue a group of children, a little bit more than half of our sample, that remained stable in the severity of their autism from age 3 to 6. Another group in green, with almost 29% of the children in the sample, are children that significantly decreased in the severity of their autism symptoms during early childhood. And the third group in red are children that increased in the severity of their symptoms from age 3 to 6. So about 17% of our sample increased in their symptoms. And we also found relationships between these patterns of symptom change to biological variables. So this is work done by Derek Andrews from the Autism Phenome Project. And what Derek found was relationships between symptom severity change patterns and white matter development in the brain. So what you see on the left in panel A is that the children, the same children that I showed you in the last slide that increased in their symptoms during early childhood, they also had slower white matter development in a specific area of the brain. And then what you see on the right in panel B is that the children that decreased in their autism symptoms during early childhood had greater increases in white matter development in another brain area compared to other children. So we are starting to see relationships between these behaviors and patterns of development in the brain. We later wanted to, these children, they keep coming into the lab, right? We're following their development. So as they continued to come in and they grew older, we wanted to extend the trajectories, and we wanted to see how they are doing as they enter elementary school and in the middle childhood years. So we extended the trajectories, we reshuffled the sample, and what we found again was these 3 groups. So in blue, the L stands for longitudinal because this trajectory is longer than the first one. It starts at time 1, which is the beginning of early childhood, age 3, and it ends at age 11 and a half. And in blue, almost half of our sample are the group of children that remain stable in their autism symptoms across childhood. In green, 27% are the group of children that decreased in the severity of their autism symptoms across childhood. And in red, 24% are the children that increased in the severity of their autism symptoms across childhood. So just to recap question 1, how common is change in the severity of autism symptoms? We found that about half of the children in our study, so 46 to 51%, around half, demonstrated significant change in the severity of their autism symptoms across childhood, so from age 3 to 6 or 3 to 11. Our second question was, does change differ between childhood periods? And because we had now 3 time points, we wanted to compare changes that happened during early childhood with changes that happened during middle childhood. So we compared change from time 1 to time 3, which is age 3 to age 6, with change that happens between time 3 to time 4. So change that happens during middle childhood from age 6 to age 11 and a half. And looking at the entire sample combined, what we saw was that for the children that increase in their symptoms, that their symptoms worsen over time, it is equally likely to happen during either early or middle childhood. Children significantly increase during both periods. But for decreasing in symptoms, children are much more likely to decrease in the severity of their symptoms during early childhood, during preschool years, than they are during middle childhood, during elementary school years. And we also wanted to evaluate these differences between change during the childhood periods at the individual level as well. This figure is very complicated, so let me just walk you through it. On the x-axis below, the axis that is lying down, what you see are changes in severity. So the positive numbers show increases, an increase of 1 point, 2 points, 3 points, or 4 points in the axis of the calibrated severity score. So going up by a point or 2 points or 3 points, which is a worsening trajectory. Or the negative numbers are decreases in symptom severity. So reducing by 1 point or 2 points or 3 points. So the x-axis shows this during early childhood from age 3 to 6. And then the y-axis, which is the axis that is standing up, shows the same thing, decreasing or increasing in symptoms, but during middle childhood. And each dot in this figure represents a child in the study. And it is colored by their group membership. So the blue are stable, the green are decreasing, and the red are increasing in symptoms. And this is a complicated figure. Let me just tell you that what we see here is that more than 60% of the children in our sample show different patterns of change across periods of development, of childhood. So we found patterns like decreasing severity during early childhood and then increasing severity during middle childhood, or the other way around, or stability during one period and change during the other. So most of the children show different types of change across development. So just to recap on question 2, we asked, does change differ between different childhood periods? And across children, we saw that increasing severity can happen during either early or middle childhood, but decreasing severity is much more common during early childhood when children are in preschool. And when we looked within the children themselves, we found that change differs over time. The children can either increase or decrease during one period and then remain stable or going the other direction during the later period. And this brings us to our last question, question 3, which is, what would predict if a child increases or decreases in their symptom severity across childhood? And we looked at different variables in relation to symptom severity change, so different factors for the child's life. And we found 5 factors that are associated with symptom severity change and 1 that was not. So let me start by talking about IQ. We looked at children's cognitive ability in relation to their patterns of change in autism symptoms. And what we found, what you see here in this figure, are the 3 groups of children in relation to their patterns of change during early childhood, from age 3 to age 6. And what we found was that the children that decrease in the severity of their autism symptoms during early childhood have higher cognitive abilities, so higher IQ scores compared to other children at both age 3 and at age 6. And these children also make IQ gains over time. So in parallel to their decreasing in autism symptoms during early childhood, they are also gaining in their IQ, in their cognitive abilities. While compared to them, the children in the increasing severity group, the children that increase in their autism symptoms during early childhood, they have lower IQs at both age 3 and age 6, and their IQs remain stable. So we did not see that they have a significant increase in their IQ. But this relationship between IQ and change in autism symptoms happens only during early childhood. As children grow older and they go into middle childhood, we didn't identify any patterns that associate these two things. So IQ seems to be more either impacting or impacted. We don't know, right? Because these are correlations, but it is strongly associated during earlier ages rather than later ages. The next thing that we looked at was sex differences. We wanted to see if we can identify differences between boys and girls on the spectrum and how they change in autism symptoms. And what you see here in this figure is a distribution of all the girls on the left and all the boys on the right into the three symptom severity change groups. And you can see that the highest columns are blue, right? Because both boys and girls have the strongest tendency to remain stable. But if change does occur, then for girls, they are much more likely to decrease in the severity of their symptoms rather than increase in their symptoms. While for boys on the right, there was no differences between the green and the red column. So if boys change, they can change in either direction. There's no one change type that is more prevalent for boys. And this really surprised us. This was really, really interesting. So we decided to dig a little deeper, and we wanted to understand, where is the signal coming from? What's changing? How is it changing? What specific behaviors are girls improving in? So what we did was we created these trajectories based on the calibrated severity scores, the ADOS calibrated severity scores for the boys and for the girls. I'm sorry for the gender, but the girls, you can see the girls on the purple and the boys on the blue. And what we found, evaluating symptom trajectories across childhood for all the boys and all the girls, we found that girls showed a statistically significant decrease, a substantial one, in the severity of their autism symptoms from age 3 to age 11, both in their total symptom severity and also specifically in their RRBs. And we found and we saw that this was especially prominent during middle childhood, from time 3 to time 4. While for boys, all three trajectories, when I say 3, I mean the total symptoms, the social communication symptoms, and the RRBs remain stable. We also found patterns of change in social communication symptoms, but they were not statistically significant. That's why I'm not speaking about them. So we found differences in the calibrated severity scores. But again, these are summary scores. They're showing us that there are differences in how boys and girls change in their symptoms, but they're not showing us how. They're not showing us where from. So we dug even deeper. We went into the item level, and we looked at the different items in the ADOS assessment. So items, specific items look at specific behaviors, and we wanted to know what is going on with the specific behaviors that these boys and girls are showing in the ADOS assessment. And what we found, so you can see here in the slide how the different, these are only behaviors that significantly changed for boys, for girls, or for both. So you can see how specific behaviors changed across childhood. But when we look overall, what we see is that girls significantly decreased in 7 of the ADOS items. So 7 specific behaviors that we evaluate in the ADOS, and they remain stable in the rest. While for boys, they decreased in actually 9 of the specific behaviors that we look at in the ADOS, but then they also significantly increased in 2. And they increased in 2 important. For instance, they increased in the severity of the shared enjoyment and interaction, which means that the reciprocal quality of the interaction that, on average, at least these boys were able to make during the ADOS assessment, the quality is decreasing with age. So when we're trying to understand what is going on with boys and girls, what is differentiating boys and girls, we see that for girls, they change, they either, if they change, they decrease in severity, they get better over time, or they remain stable. And actually about half of the girls in our sample decreased in the severity over time of their symptoms, and the other half remain stable. While for boys, it's going in every direction. Boys are getting better, they're getting worse, they're remaining stable. There's just more variability. While girls, their trajectory is more consistent and homogeneous for this group over time. The third factor that we looked at in relation to symptom severity change is adaptive functioning. We wanted to see whether children who change differently in core symptoms, whether this is associated to how they function in everyday life. And it's quite remarkable that at time 1, at age 3, all 3 groups had the exact same adaptive functioning level when they entered the study. But by age 6, by time 3, after the change had already occurred, after they had already decreased or increased in symptoms, then the group of children that decreased in the severity of their autism symptoms had significantly higher adaptive functioning abilities compared to the children that increased in severity. And this was very, very interesting because of how adaptive functioning is meaningful for people's lives, for children's everyday lives. And we wanted to further explore the trajectory of this group, the red group, the children who increase in their symptoms during early childhood. So we looked at this group's trajectory of adaptive functioning over time. And what you see here in the figure are in red is the overall adaptive composite score, so the overall score, and then the 4 subscales that we look at when we evaluate adaptive functioning, which is communication, daily living skills, socialization, and motor development. And what we found in this group of children is that in parallel to their increasing symptom severity during across childhood, they were reducing in their adaptive functioning standard score. Now, this does not mean that they were losing ability. They were not decreasing in adaptive functioning, but they were decreasing in the rate at which they gain abilities compared to other children. They were slowing down in the rate of their progress in adaptive functioning. Next, we looked at parental characteristics. We wanted to see whether something to do with the parents is related to symptom severity change. And what you see here are the distribution of education level for the fathers above and the mothers below in the 3 symptom severity change groups. And the lighter the color, the higher the education level. So when you see distributions that have a lot of light in them, it means more educated parents, and distributions with a lot of darker shades, it means lower education level. And what we found was that for both fathers and mothers, children who decreased in the severity of their autism symptoms had older and more educated fathers and mothers, while children who increased in the severity of their symptoms had younger, less educated parents. And this maybe isn't a big surprise, right? Because education level is associated with SES and with access to resources and the ability to advocate for your children and receive a diagnosis and get intervention. So this was not a big surprise, even though it's not a happy finding. We next looked at co-occurring mental health conditions. I know it's long, bear with me. We looked at co-occurring mental health conditions to see whether they are associated with change in children's symptom severity levels. And we found this subtle, almost weak relationship between symptom severity change and mental health conditions. But when we broke down symptoms into the 2 domains, so we looked at change in social communication symptoms and change in RRBs, that's where we found a significant relationship to change in mental health conditions. So in order to evaluate this, we redistributed the sample And what you see here are groups based on change in the two domains. So on the left, you see two groups in the two shades of pink and purple in panel A. The pink group are the children that remain stable in their social communication deficits during middle childhood. So this is the middle childhood period. This is age 6 to 11, elementary school. And a large group of children remain stable in their social communication symptoms, but we also found a group of about 21% of the sample that experienced a very significant increase in their social communication deficits as they entered elementary school. So on average, this group of kids increased from a 4.7 on the ADOS calibrated severity score metric, which is a low score, to 8.4, I think, by the time that they were 11 and a half, which is a very high symptom severity level. So these children experience this very clear worsening in their social communication symptoms during middle childhood. And we looked at their psychopathology levels. And what we found was that in parallel to this increase in social communication symptoms, they had an overall increase in psychopathology levels in different areas. So on the top left figure, you see anxiety measures. They increased in internalizing symptoms. They increased in their anxiety levels and in their DSM-based anxiety symptoms. And below on the left, you see this group's anxiety level based on the ADIS, which is a parent-administered anxiety interview assessment. So 86% of this group of children had met the clinical criteria for an anxiety disorder by the time that they were 11 and a half. We also see on at the top right figure their ADHD levels and symptoms, which also rose across middle childhood. And on the figure on the right, at the bottom right figure, what you see is their overall psychopathology levels. And these children, each one of these children in this group had psychopathology levels, which were clinically significant by the time that they were 11 and a half. So they had this increase of both social communication deficits and overall psychopathology levels. And when we look at change in RRBs on panel B on the right, we distributed the sample based on change in RRBs. So we found three groups. In dark green, it's this very small group of children that increased in their RRBs. In regular green, you see a group of kids that remained stable in their RRBs during middle childhood. And in the light green, like the grass shaded green, there is a group of about 23% of the children that really, really reduced in their RRBs during middle childhood from age 6 to 11. But what was interesting about this group is that in parallel to having this very substantial improvement in their RRBs, they had a worsening in their anxiety level. So you can see at the top left figure, their anxiety levels that increased based on the CBCL. And these dotted lines are lines that represent the threshold for clinical significance. I didn't say this. On the right figure, on the left figures below, you can see, just like the previous group, these children's anxiety levels based on the ADIS, the anxiety assessment done with parents when they were 11 and a half. And 94% of this group, of the children in this group, met clinical criteria for an anxiety disorder by the time that they were 11 and a half. And this, unlike the previous group, this was the only psychopathology characteristic or the only mental health condition that we consistently found across all the different children in this group. So in parallel to their decrease in their RRBs during middle childhood or following their decrease at age 11 and a half, almost all of them met criteria for having an anxiety disorder. And this is the last thing, the last factor that we evaluated in relation to symptom severity change. We wanted to see whether a child's initial severity level, when they come in for an assessment where they're about 2 to 3, whether that can predict how they will change in symptoms across childhood. So what you see here is a scatter plot with each dot representing a child, the child colored by their group membership. So it's showing the trajectory that they will go through during early childhood. And if you look on the left at time 1, so this is age 3, when kids just come into the study, just after they get their diagnosis. And when you look for the green dots, these are going to be children who will decrease in the severity of their symptoms during early childhood. And the green dots, they run all across the range of the ADOS axis. So starting at 4 and all the way to 10, because children that receive a 1 to a 3, they're not in our group. They don't receive a diagnosis. But the kids who will undergo improvement in symptoms, they start off at a wide range of symptom severity levels when they are 3 years of age. So this shows us that initial severity level at the time of diagnosis is not a good predictor of how a child will change in their symptoms across childhood. So that was a lot of different factors that we looked at. So let me just recap. We wanted to see what predicts increase or decrease in symptom severity across childhood. And what we found was that decrease in severity was associated with being a girl, with having higher IQ and adaptive functioning during early childhood, and with having older and more educated parents, but not with children's initial severity level when they are 3 or when they come into the lab. And specifically, decrease in RRB during middle childhood was associated with having more anxiety later on, while increasing in severity, it was associated with having lower and stable IQ during early childhood, having lower adaptive functioning at age 6 that further decreases compared to other children across time, and having younger and less educated parents. And specifically, increasing in social communication symptoms during middle childhood is associated with having higher and increasing mental health occurrences during the same age. So we're thinking about what these findings could mean. How do we translate them into real life conclusions about people, children's lives? And the first thing is that it seems that children's symptom severity level can change substantially during childhood. And these change patterns are not linear. So change can differ between different periods of behavior. It doesn't happen in the same way across time. Children's characteristics, such as their sex, IQ, and adaptive functioning, and their mental health conditions, as well as characteristics of their environment, of their parents, can predict if they either decrease or increase in their symptom levels across childhood. And last, and I think very, very importantly, we found that children have the potential for different symptom severity trajectories, regardless of their initial severity level during time of diagnosis, which also means that children that come in with a very severe symptom level, when we first see them, they have the same potential for improving in symptoms as other children over time. And we're also thinking about how to take this further, how to keep exploring these questions. The first thing, which is the obvious thing, is to keep following the children as they grow older, right? They're going into adolescence. They're coming in now for time 5, which is age 15 to 19. We already found a group of children who exhibit increasing social communication challenges as they grow older. Now, adolescence is a period that is characterized by social challenges. Everything is becoming more complex. Being a teenager is kind of like a jungle. So we want to see how the children fare concerning their symptoms. specifically their social communication symptoms during adolescence, as their environment changes. We're also very interested in these interactions that we saw between symptom severity change and other factors. We want to see how these interactions keep unfolding across time and development, and whether we can try to use them to create these developmental or longitudinal subtypes of autism, not based on children's characteristics, but based on how they change in several of their characteristics over time. This can, of course, help us to try and identify resilience factors, as well as periods which are more susceptible maybe for worsening, to try and prevent that from happening, to identify specific needs, and of course the holy grail to try and personalize care. And last, we're very interested in the sex differences that we found. This was a surprise to us, that girls are doing better than boys across time, over time, in the level of their symptoms. But after we found this, other samples around the world have started to find it as well. So this is something that is replicated, and we want to try and understand what's going on with the girls. Now, there is a body of literature that talks about camouflage. I'm sure some of you have heard about it. Camouflage of symptoms means to try and mask your autism symptoms in social situations in order to appear less autistic to others. And studies looking at camouflage have shown that it is more prevalent in girls than boys. So when we look at these trajectories for the girls in our sample, we are, a question that comes to mind is, are we actually seeing a better prognosis for girls for their core symptoms? Are their core symptoms really reducing over time? Or are we actually documenting the fact that girls are gaining the ability to mask their symptoms with age? And that's a really important question to try and understand what we're seeing. And we are exploring that question in a new study that we are doing now at the Mind Institute. So I will conclude. I'll just thank my graduate advisor, Dr. David Emerald from the Autism Phenome Project and the Mind Institute, and everyone at the Autism Phenome Project and the Girls with Autism Imaging of Neurodevelopment study, the GAIN study, which is the study in APP that is focusing on the girls, the UC Davis Mind Institute, and of course, all the funding agencies and all the families and the children that are taking time year after year to come in and take part in these studies. And that's it. And thank you everyone for listening today.
Okay, great. We've got time for just a few questions. There are many questions, but you just actually addressed some of them in your last couple of slides, so it's great.
Okay.
And you talked a bit about this, but maybe you can clarify a little bit more about the types of therapies and things that they were using during so when the participants would come in, obviously they did the ADOS. What other instruments were used or different therapies?
So it's not therapies. These children, most of them just received intervention in the community most of them from the time that they were diagnosed. And that's something that we try to keep record of and collect data about. But when they came in, they did assessments. Visits they take several days because of the number of assessments that are collected. So behavioral assessments would include the ADOS, which is what I talked about today, cognitive assessments, so IQ assessments. They would meet a physician that did a medical exam. There was a blood draw. They did MRI during their sleep. So they came in during the night to do the MRI during natural sleep. Language assessments, memory, academic skills. So it was yeah.
A lot of them, I think the other part of this question people are asking, I didn't ask this quite correctly, is just, so you were seeing a correlation between kids who were getting say, speech therapy and OT and ABA and everything at school. And then you were seeing that the kids who didn't have access to those same resources were having a very different experience. I think that's what you were describing in the data when you talked about the education level of parents.
So that's interesting what you're saying. So we did look at children's intervention history.
Yeah.
And one thing that we did find is that children that received more intervention when they were toddlers. So before entering the study, these children, I didn't talk about this, but these children actually, so the children that decreased in their symptoms during early childhood had received more intervention during their toddler years compared to the children who increased in their symptoms during early childhood. And that makes sense. But when we put that in the same models that we were evaluating, along with parental education, it became non-significant, which means that it's working through parental education. It means that the fact that some parents had higher education level was the initial factor that contributed later on to some of the children receiving more intervention, and then which led to or was associated with more decrease in autism symptoms later on. So the way that we interpret it is that, yeah, that parents that have higher education levels, they just have access, right, to more resources, including giving their children the intervention that they need.
Right, that early intervention that, yeah, that they have
Yeah.
access to that, and maybe the connections to get it sooner. So, all right, another question. Several people were really impressed with the data about anxiety and not surprised. So one question was, do you think the increase in anxiety is directly related to their experiences as they start school, all of that uptick in the peer interaction, or is there some other factor that they suspect might have to do with that?
Yeah, so I think it's very interesting too. And as someone that works with children on the spectrum, it's not surprising that we see increases in anxiety levels. So we did have an overall increase for the sample. So a lot of the kids in the sample increase in their anxiety levels. It might be associated to different things. When they entered school, we know that there are less intervention hours and resources that they have compared to preschool. We know that they are faced with multiple new challenges, like being in a classroom and creating a relationship with the teacher and recess and self-regulation in a classroom that has probably a lot of sensory input. So we know that they are faced with many challenges. It was interesting to see that the kids that increase in their anxiety the most are the kids that decrease in their RRBs. A lot of people talk about RRBs as a self-regulation, an emotional self-regulation mechanism. We think that that theory is very interesting in relation to what we found, because if some children are not doing their RRBs intentionally, if they're trying to not do their RRBs because of stigmatization or the surrounding, this environment that they are in, it might be coming at some kind of cost. We don't know. It's a possibility. We need to further explore it because this is a correlation. It's not, we don't know what's exactly leading to what. It's a relationship.
Right. I know we're almost out of time. I'm just going to ask one more question. I know it's late where you are. So
It's okay.
yeah. So one of the things that there's a theme here of different kinds of questions, and a lot of these questions are specifically asking for, medical recommendations or treatment recommendations. I know we can't do that. So if people are really seeking out kind of where are we right now, what interventions would help me right now, what would you recommend if a parent came to you and said, okay, we know we're still on the spectrum, we've got all these things, my child is 11. What should they think about in terms of evaluation and maybe intervention?
So our study wasn't looking at types of intervention or comparing types of intervention. So based on these findings, I can't say anything specific. There is an abundance of evidence in favor of early interventions. One of the things that we found in our studies is the increase in psychopathology that a subgroup of kids are experiencing as they grow older. And especially we were looking at middle childhood, so elementary school years. And we did find a lot of anxiety. A lot of kids are showing ADHD symptoms. For us, one of the things that it showed us is that during these specific years, parents and therapists need to be aware of the fact, like hold it in their mind, that this is something we need to be on the lookout for. We need to see how the child is doing. We need to know that this is something that might appear. This is a challenge that might come up